All right, so I am Jonathan Blake, and this is Dr. Gabby. We are from a program called the Child Psychiatry Consultation Program. And if you grabbed a handout when you walked in, you can go to our website and check more of it out. But we consult with primary care doctors across the northern, 15 counties of Wisconsin, and then also down in Milwaukee. And so primary care docs can consult with Dr. Gabby as one of the psychiatrists, and then two other psychiatrists that are on call. So we've been doing this for probably about a year now in the northern part of Wisconsin and hoping to expand to the rest of the state. And so they had asked us to present the trauma-informed care information to you all. So if you have questions outside of that, I left also a business card on the table. If you want to grab one of those, you can email me and ask any questions you need to in relation to the program itself. But I'll let Dr. Gabby talk about her trauma-informed care.
Well, I just wanted to say thank you for inviting us to be part of this series. It's a very important topic for everyone to be aware of, especially if you're in the caring profession, but basically if you have any relationships at all, this is important stuff to have at least heard of and factor in when you're with other people. Trauma-informed care, I've got a little bit of info in here just about the definition of trauma. So if you're following the whole series, you might yawn through that part, but just to be complete. Then I wanted to talk more about what factors can help an organization provide services that are trauma-informed. And the purpose is to not inflict more trauma on people and not to drive them away from services that might be helpful inadvertently. So I want to go through that. And I have a little bit of info in here about vicarious trauma, but that's just a teaser because next month's presentation is going to be on that topic by itself. So I'll talk about that just a little bit. I am happy if there are questions in the middle or comments, just wave at me and I will, we'll discuss what's on your mind at that point. So let me see if this is going to advance the slides or not. Maybe not. Let's see if I can do it this way. Okay. We are salaried employees of Medical College of Wisconsin. We don't get paid. We don't have any products on trauma-informed care to sell you, darn. So we don't have any conflicts of interest in that regard. What would I hope you'd come away with after this talk? Exploring the definition of trauma. I'm a child adolescent psychiatrist, so the past 20 years or so has been mainly working with kids and teens, but their parents also will sometimes say, well, was that a trauma? And my response to that is your brain decides that. There's not a threshold or a level that the outside world can say you shouldn't be traumatized by that. And the younger you are, the less it takes because of interpretation. A little 3-year-old is not going to be able to put things in context the same way as a 13-year-old or a 33-year-old. I also want to learn to identify trauma response behaviors. So if you have been through a trauma, how might your behavior change after that? Then we're going to move on to the meat of the talk, which is trauma-informed care. What principles should an agency, organization, and the people that work in it keep in mind when they're trying to recognize that trauma has happened to a big number of people, and that if we don't understand that we're not going to be able to be as helpful as we could be. So there's kind of a mindset to try to do no harm in that regard, and so we'll go through that. And then end up just a little bit of talking about how to avoid traumatization and vicarious trauma. So, it shows up better on there. So trauma, it's an event that is extremely upsetting and at least temporarily overwhelms your internal resources. So a single event could be multiple events over time. There could be 3 people present at a certain incident. Some brains will hang on to it, some brains will not. The concept of resiliency is very important, and I'm not going to touch on that a whole lot today, but just hang on, because in the fall there's going to be a whole conference on resiliency. So that's the basic definition of trauma. So they're overwhelming, they're uncontrollable, and your psychology changes if you've been exposed to trauma. And leaving a person in the moment of the trauma, feeling helpless, vulnerable, can't control anything, feel a loss of safety. So that's at the time of the trauma. That's part of the definition. So it can be a single event, a car accident, a house burning down. Those are common things when I'm trying to screen for trauma and people that I'm meeting with to try to assess what they've been through and what might help them. And those are things that if you've been through it, you'd say, well, gee, yes, I was. It's harder to ask about complex trauma, which I'll talk about in a minute, and especially in younger kids. They don't know that that's not what we all go through every day. So it's hard for them to understand that maybe getting hit is something you might tell somebody about, you know. So significant health concerns, hospitalizations, medical procedures. Even adults certainly can become traumatized through a medical procedure, but at least we understand why we're kind of allowing somebody to hurt our body in a surgery, for example, or a procedure. So the younger you are, the less it's going to make sense at all. And when I've worked on inpatient medical wards with kids, I've always been really concerned, should the parent be in the room or not? If the parent is right there while the child is being harmed by the doctor, that makes me worry about attachment. And with my own kids who are now 18 and 20, I would be the one holding them when they're getting their immunization shots, you know, so mama's here, you know, and then, you let somebody hurt me. You know, so it's a complicated issue of what is traumatizing and what isn't. But we'll find that what comes after the trauma can help a brain hang on to it, or maybe be able to take some of the heat out of the incident and store it in their more normal memory stores where they can choose to pull it out and think about it, or they can choose not to, instead of the trauma kind of being in charge of their brain. So witnessing scary things and certainly experiencing abuse. I'm a big advocate to remember the cumulative effect. So there might not have been one incident that ever brought a person to an emergency room, for example, when we're talking about domestic violence or physical abuse. But the cumulative effect can overwhelm the brain at some point, and the longer it goes on, the harder it is for the brain to defend itself against something, especially in a little kid that seems like this is just what my life is going to be like in the case of ongoing physical abuse, sexual abuse, and as we'll see, even neglect. So neglect, nothing was added to the kid's life. They just didn't get what most of us hoped we got in order to be as resilient as we can be. So neglect is, it's hard to ask a family, you know, it's hard to screen for neglect with the family in front of you. You know, do you have enough food in your house? That kind of thing. But it's very important to do because the damage from neglect can be very high. The damage on kids from witnessing domestic violence is certainly very high as well. And I've had a lot of parents say, well, they didn't hear anything, or no, they probably heard something, but they were too little to understand it. Or, well, we only fight when they're in the bedroom with their door shut, so they never saw anything. And just to try to help them understand that the whole body is on high alert when there's something that scary going on. So you're seeing, you're hearing, you're smelling, you're having sensations, and they can certainly have a lasting effect on everybody involved. So single event, connected series of events, chronic lasting stress without relief in between traumatic events. And as of yet, and this quote, trauma is underreported and underdiagnosed, is from 2004, but I think it is getting better, but it's still a problem. The ACEs study, you probably heard about that a lot. I just wanted to include this as a way to try to quantify things so that we can begin to wrap our minds around cumulative trauma and the damaging effects. So hopefully you've heard of, has everyone heard of this study, the ACEs, Adverse Childhood Experiences? The more you have, the harder your physical and emotional life will be, and perhaps even the shorter your life will be. So it's really important to screen through this level of trauma, at least. So it can cause various medical illnesses, and that the ACEs study was maybe the first time where somebody tried to see, is there a causal effect? So instead of just a correlation. Because if there was just a correlation, it might be easy to say, oh, it's just if you're poor, or it's just if, it doesn't have to be anything psychological. But psychology changes the brain in good ways and bad ways, unfortunately. So you can end up with more medical problems as well as mental health problems. So in the immediate moment of trauma, there's a sense of helplessness, horror, lack of control, feeling completely unsafe. And then you get over it, right? Well, some people do. They can talk about, yeah, that was so terrible. What's for lunch? It's not anything that is so valiant that it still makes them completely horrified or reliving it, even when you ask about it directly. Other people are going to have these symptoms be re-triggered. And flashbacks, the theories in kids, and I keep talking about kids, but kids are important because the younger we recognize things, the earlier we can try to help. But the theory is that children's brains, at least prior to 9 or 10 years old, aren't really able to form a flashback. So I do ask about that. I ask the child, does it ever feel like you're actually living through it again, seeing it, hearing it, smelling it, like you're in the middle of the worst dream ever, except it's in the day. And I've not had kids say yes to that. You'll have adults that say yes to that too. So, yes.
One question. So does that mean that after around age 9 or 10, they can have flashbacks of those memories, or they can't actually have a flashback before age 10? I guess I'm confused. What?
I think it's something about the storage, that there aren't neural connections where they can access it in that form, like a specific memory. They can remember bits and pieces. And remembering is different than a flashback. I think there's something about storing a flashback which is more complicated than storing the bits and pieces of how did I feel and what did things look like and smell like. Because certainly they can be triggered by all that. So the information has got to be in there. And even in infants that have lived through things, they're trying to study, because you can't just ask them, why did you just go, when this noise, or when you smelled beer or some other fairly common trigger, beer, the smell of beer is a big one for kids. When bad things happen, they often would remember the smell of alcohol, for example. But they might not be able to say, well, yeah, that smells like Grandpa's breath, for example. So as far as a formed flashback where you just kind of hit the tape and it rolls, that seems to be more of an adult phenomenon, or pubertal and older. But as far, I'm not an expert on, well, why? So when triggered, these things can come flooding back. Flooding, I'm looking at loss of bladder or bowel control. That would be a super severe trauma. I've had kids, because of attachment issues, look what I'm going to do on your chair, but I've not had it where it seemed like it was the midst of a triggered episode, at least not in my office, but in the real world, I don't doubt it. So in the face of overwhelming trauma, the body tries to protect us, the brain and body. Various responses can be triggered without thinking. So this is the part I try to help teachers and parents understand, is that it's not like the child, or the adult for that matter, stops and says, should I fight? Should I flee? Should I freeze? Or should I go along with it? This is a reflex that the brain sets up it does not want us thinking, gee, is this saber-toothed tiger friendly or not? It's just like, get the heck, just cruise out of there. So logic and your frontal lobe does not have much work to do in the face of trauma. And it's supposed to help us, right? A fear reaction, I think it's easy for adults to forget that fight is part of a fear response. And I don't know if you work with kids or in schools, but kids are fighting more than ever. They're fighting about everything. They're fighting for no reason. And I'm always thinking trauma. Their fight or flight mechanism it's the first thing. And it's getting triggered repeatedly when the playground lady goes, don't do that. Just that tone is like, okay, fight, flight. They're not thinking it over, but they're ready to go. And then the good-hearted teacher or therapist thinks, well, I'm going to calm them down. And so they touch them, and then boom, it's triggered. And then, why did you do that? And the kid's like, I don't know. And the kid is right. They don't know. They don't know why they did it. It's a reflex set up. You shut down non-essential tasks, and rational thought is less possible at this time. This is going to be important as we start to think about patients or clients or people we work with, and why sometimes things change suddenly, we get fired or other bad outcomes, and then we're just like, what? What happened? So the images or pictures as far as information storage, that is like a true flashback. It doesn't mean there might not be kind of images that kids will relive in dreams. Adults also can have nightmares, but flashbacks during the day. The body remembers the trauma you've been through. So sometimes they would say, like, I've been told this happened to me when I was little, but I don't remember it at all. But they're hyper startly and they're ready to fight, and we're not supposed to guess about trauma. We're supposed to try to figure out what actually happened to the best we can. But little kids can't help us a whole lot. They have the end product of it, but they don't remember why this happened to their brain. But they can be triggered. And it can feel as intense as if they're right there in the middle of things. So you've probably already heard, the Vietnam War probably brought out the most research surge in post-traumatic stress disorder. There's some men in here. I don't know if it's because men go to war and they're supposed to not say that they've been damaged by anything. I'm not sure, but the fact of triggers and things, we owe a lot to research done with the helpfulness of Vietnam vets that are willing to try to help. They wanted to figure it out for themselves, but also they were being generous with the rest of us to try to say, this is what I'm left with because of what I've been through. Warning signs that things are turning badly, that a person may be getting triggered. We've all seen this when we're arguing with our significant others, right? The legs shaking. I thought you paid that bill, and people are moving around more and spacing out, or even losing logic, like rational thought. If you get to that point, it's time to say, okay, let's kind of back up a little bit, because it's not going to be pretty, right? If you just push on to a full-blown triggered reaction. But if you have any of these reactions coming out and you don't know why, it's time to back up a little bit, and that's the compassionate thing to do. It isn't giving in. And when I work with parents, I'm trying to help them understand that we've all been through plenty of things. It's not a contest. If we're all traumatized to some level by certain events, so be it. So to your kid, the kid isn't going to see this as fair, and it's not going to seem fair. It's like, well, I went through twice as much as him. Why is he, startly, and he's acting like he's afraid of me? I didn't even do anything yet, So that's concern, and I try to help people recognize that these are signs that things are not going in a good, rational direction. And if it's your role to, might be a time to back up and try to gently sort through what just went on just now. We were talking, and and it seemed like we were communicating, and then it feels like you kind of had to push back. Can you help me understand what was going on then? Now let's get to trauma-informed care. So are we believers that there's trauma in the world, that brains hang on to a reaction and can be re-triggered by lots of things, and none of it has to make rational sense? Are we believers? Okay. So then we'd be fools not to use this knowledge when we're trying to work with people, and certainly when we're trying to help people. We don't want to drive away people who need us the most, and it's remarkably easy to do if you don't keep some principles in mind. So trauma-informed care, TIC, understands trauma. So it has the idea that there may be trauma in any person I meet, promotes safety by trying to recognize that fact and design even the look of your physical plant so that it's not off-putting and potentially triggering to people who are coming in and hoping things will go better for them, not worse. And competency, if you really want to help somebody, it's nice to be able to clear off some of that defensiveness. So you've probably heard patients or clients or thought about customers or things like, they're so annoying and they don't make sense and I never do anything right for them. So just kind of backing up and thinking, are they getting a message from me that something's way wrong with them and they need to change everything? So your competency increases if you are feeling and behaving on the same page as the person you're trying to help. Control, choice, and autonomy. Who likes to be in charge here? Me, everybody, right? Yeah. So there's a power differential, just like right now I'm standing up, so this is like bad, right? I'm supposed to, I'm standing up because I'm short, and if I sat down, I'd be looking up at my screen. But if you don't have that frame in mind, it's easy to have people feel like you're an authority, and people who've been traumatized are sometimes or oftentimes fearful of authority because, especially if you're little, if the biggest person wins, and if winning means you got hurt, you're automatically going to be ready to defend yourself if the person says, come in, and they don't say your name and they don't look you in the eye and they march ahead of you down the hallway, and if they stand and make you sit. And so there's all kinds of things to keep in mind. It sounds like so complicated. How could we ever do this right? But if we don't try, we're never going to get there. And some of these, many of these factors are not highly complicated. It's just a matter of thinking about it when we're heading into situations working with other people. Promoting cultural competence is really important too, because there is a power differential for the most populous or richest culture for others to feel like, ugh, I have to conform, or they don't respect me, or differences might be seen as bad. So recognizing that it doesn't have to be a competition. All cultures can be meaningful and useful and valuable. Integrating care is important. And when I'm thinking about agencies, when I was putting this together, I was thinking about it, well, more than I ever had before, but just thinking that if you're in like an office setting and your receptionist is nasty, which who would hire one, right? But, let's say they're just having a bad day that day, like sit down, she'll get with you soon. You're gonna have to do repair work then when you finally meet the person. You won't even know it though. But they might come in defended, already ready for a fight because the first person they met when they're trying to get to you made them feel worth less. Not intentionally, perhaps, but still all adds up. So integrated care is having everybody in your agency on the same page and understanding that what they do does count. It does matter. You can have the worst day ever, and if it is the worst day ever, you probably should call in sick. But if you happen to be at work on your worst day ever, that's not their fault. You know, you're getting paid the big bucks to, you know, to do what they need and to keep your own psychology as far out of it as you can, as far as adding to somebody else's burden. Understanding that recovery is possible, no matter what the person's appearance is a really important thing to hang on to, because I'm sure we've all met people like, oh my God, that person must not have a friend on the planet, and they never will. You know, like somebody that's super duper nasty. When I meet a person like that, I just start to imagine, like, what kind of horrors might this person have been through to make a human, which is a social critter, try to keep everybody else that far away, and to their own detriment. But what have they been through that makes them decide any kind of closeness, even just like, oh, hi, is too, makes them too vulnerable. So it's really helped me, you know, meeting people and working with all different personalities to have a thought like this. It didn't have a name for it 20 years ago or 25 when I started in the business, but just recognizing that people have often been through a lot, and of course it's going to affect their behavior and their relationships. So 7 ingredients. There, you know, 7, there's 20, there, you know, pick your number. I just thought this approach kind of gets it down to nuggets that we could talk about. So prevalence, that is knowing that it's a common phenomenon, that people have been traumatized, and ourselves as well. So I'll throw that in the whole along the way, you know, understanding our own psychology. The more you understand it, the more effective you can be if you're choosing to try to help people, because any relationship has 2 players in it, and the more you understand what you might bring automatically, if you've ever heard of transference. Like, have you heard of Freud? He was one wacky dude. But he did have some good concepts, and I think that is one, and that is recognizing that people are going to have automatic assumptions when they first see you before you even open your mouth, and their brain is going to be matching, you know, oh, she kind of talks like my aunt that I couldn't stand her. You know, she brought the icky, you know, Jell-O salad to Thanksgiving or whatever. So understanding that 2 people, it takes 2 people. You might be trying to understand their psychology, but trying to understand your own can be helpful, especially if there's trauma. So prevalence, so recognizing, gee, I think there's a lot of this out there, so perhaps this person has a trauma history. Impact, understanding that it's not like my mom would say, well, just get over it, that was a long time ago. You know, it has an impact. It can change the brain, and it can cause automatic responses, and then no fair trying to get them to make sense of it in words. You know, it's not their fault. They've been through a trauma, and that their brain has automatic reactions. So understanding that what we've been through does make us the way we are, you know, like it or not. Our free will can make us decide we would like to try to alter that, smooth out some edges here and there, so to speak. But just recognizing that that is the result, can be the result of trauma. The traditional approach, and this is talking medical or psychiatric, but it really can be just the traditional approach in any context of working with people. If somebody comes in and says, you know, I'm here for my appointment, what might that mean? Oh, they must be depressed. Well, maybe they are. Could mean your parking lot is so crowded, I had to park 6 blocks away and roll my baby and my 2-year-old and my 4-year-old down a busy street to get here. So if we just take a crack at it in the old way, we're defensive. So we're trying to think, well, so what's wrong with them? Why are they so nasty right now? Not a great way to start out trying to help anybody. And we'll get back to that. So just recognizing the impact, there might be something that got triggered along the way that is resulting in the behavior you see in front of you. So a perspective shift, this might be the most important tenet of trauma-informed care, and that is, and I already used this quote, changing from the idea of, well, what is wrong with you, to what have you been through? What has happened to you? It's just, it's an outlook, and if you just think of it quickly, it doesn't seem like it would make a big difference, but it really does, I think. So what is wrong with you? We heard that from our parents, right? You're a teenager, like, why didn't you, what did you, it's not helpful, right? Makes you defensive, that kind of language. And it also places blame. In one sentence, you pretty much predict that you're not going to be able to really understand what's going on or help very much. Changing your perspective to what has happened to you and how can I be helpful can be unspoken, but I say speak it. Why not? If that's your role to try to help people, it might make sense to at some point get to that, and there's more tips and hints on how to do that, because it's not that shake their hand and hi, I know you've been raped. That's not how you do it. I mean, you're all trained, these things, but you don't want to ignore the trauma. That's dumb. It's not going to help anybody, and your outlook on it can go a long way towards actually helping more than if you ignored it or didn't have an outlook of what the person's been through. So the traditional approach, as far as examples, well, you're sick and you're bad and you are sick and bad and here you are and I'm this authority and I'm going to just tell you everything you've done wrong in your whole life and why you're a bad parent and why your kid has ended up like this and why you're poor and all this stuff. Is that really how most of us have set up our practices? No, but if you don't think about it, it can come off that way pretty easily. Instead of, you're not sick or bad, you're injured, you've been through something that has potentially changed your brain and set up these automatic reflexes that may be getting in your way, may be leaving you farther away from what you need and deserve from the world instead of getting closer. So what's wrong with you? Not helpful. What has happened to you is the start of a conversation. Regulation. Boy, if I could, I would say 80% of the referrals that come into a child psychiatrist relate to kids, since I'm working with kids, but I would argue with adults as well, that this person cannot regulate anything. They can't regulate their sleep or their eating, certainly not their mood or temper or even their fuse, So they go from 0 to 60, they blow up, nobody knows why, it doesn't make any sense. So regulation, that's part of the damage that trauma, especially early trauma between birth and 3 years old, some would, it's not like you're, phew, I'm 3.5, I'm out of the woods now and my brain will be fine, but that's probably the most crucial period of time to get the various parts, the more primitive parts of the brain and the frontal lobe connected and understanding so that you can insert logic in there and problem solving instead of just reflex. So dysregulation, when I hear that, I'm not thinking bipolar. I mean, it might be bipolar. I'll get there eventually. But I'm thinking about trauma and attachment trouble and brain changes from being traumatized. So, and I just stuck this in there too, that there are some types of therapy, if the person can't use words very well, like they're a kid, or if they can't use words very well because it's just too hot, which could be adults, teens, sometimes kids, there are other ways where you can kind of engage the brain and help with that kind of rhythmicity or regulation. But do these studies get huge funding bases and enroll 100 people so we'll all know for sure, like in an evidence-based way? No. What gets funded? Drug studies. Do you think drugs take care of all this? Medications, I should say. No. Nope. Relationship. If your trauma comes from a relationship, it's probably more devastating than if it came from a stranger. And on the other side of the coin, your healing is probably going to have to come from a relationship as well, although I have met some wildly resilient kids who had nobody to cling to and yet they had some kind of fortitude, which I wish I could understand, and figure out how to spread that around, where even though all they had was themselves, that they didn't become defensive and aggressive and terribly threatening to others. So they looked more vulnerable because they were willing to try to make relationships. But they had nobody steady in their life. So your strong relationships before trauma can put you in a more resilient spot, and strong, healthy relationships after a trauma can help you heal and recover quicker. Reason to be. I kind of touched on this. I don't really like the wording here. I didn't come up with it. But you want a person, especially a traumatized person, you want to try to counteract something that goes with it, which is kind of vague, but it's their sense of outlook or future. Oftentimes, kids and teenagers, and I would suspect a lot of adults as well, if they've been through more typically complex trauma, but even one huge trauma, one bad day, so to speak, they unconsciously can tend to think another bad thing's going to happen anyway. So kind of like, well, why bother? It's futile. Something bad will probably happen. I'm probably not going to live very long. I'm probably not going to go very far. So that percolates under the surface for the most of the time. And one thing we can try to do is to restore hope that is your brain tricking you. That isn't. There's no logic involved in that. You're going to be more wise and worldly because you understand that trauma can happen compared to a kid who was raised in like a Walton. Do you remember the Waltons? Oh, good. Okay, so like a Walton family existence, but that you can come through strong as you ever were. You can even come through stronger, and to help a person not give in to that kind of unconscious, I want to make it conscious, but an unconscious sense that this boat is just on the waves and it'll end up somewhere, who knows, but I can't paddle it. I can't get it to go where I want it to go. Caregiver capacity. So this is where I talked a little bit about we have to understand our own psychology and trauma history and keep ourselves in a good enough spot so we actually could help somebody. And it can be hard to do that, and it can be hard case by case or day by day or even stage of development you're in. I know when I would meet a kid who was the same age and sex as my kid at the time, I would take a special interest and then I'd feel bad. That's not fair. The 7-year-old girl I met that day, I shouldn't be biased, but we all are, right? So the important thing is to just recognize and factor that in and to take care of ourselves as caregivers. So parents, to me, this is definitely a message for parents, whether they have their own trauma history, but with their children, traumatized or not. And I worked with a nurse for 15 years, and I heard her on the phone repeatedly, kids do better when moms do better, and it's true. So mom might have the best intentions in the world to help this kid, but if she's deeply depressed or addicted to things, she's not going to be able to give much because she's not going to have much to give until she gets healthier herself. So this kind of puts together, makes it look super complicated. These individual things or factors none of them are that difficult if you've thought through them. If you don't think through them, it's easy to have trouble results. So I want to go on to that. So it all sounds good though, right? I would want to see this stuff embroidered on pillows, on couches all over America, right? Share the power, communicate with compassion. It's all good stuff. But when you get busy and when you get busier than busy, it can be easy to forget these things, but then you might look back and say, wow, last week I didn't get that feeling like I really connected or I really helped too many people, and then it's time to step back and think like, what was going on last week? What got in the way? So I wanted to put in a few comparing trauma-informed care with these factors thought through and put into action versus business as usual. And this isn't to knock business as usual. It's just that it doesn't work that well for traumatized people. So it's good to think of a different way to go. So if you aren't trauma informed, you're not going to think of it. You're not going to think of triggers. You're not going to say when a person reacts a way you didn't expect, you might be just like, wow, you know what? I don't deserve that. You know, so kind of slipping into a selfish defensive mode. If we both do it, nobody's going to get helped, right? So just trying to think maybe trauma is at play. If you don't think about trauma, it's easy to say, well, this person's mood swings all over and they can't, you know, they sleep all day and they're up all night and they're completely dysregulated. They must have bipolar, or if their world outlook is odd, because especially kids will put together things and think it makes perfect sense, you know, before 10 for sure, kind of magical thinking. You might say, well, oh, they got schizophrenia, you know, because they heard mom say grandpa's flying high again, so they know people can fly, right? Well, that's a delusion, and they have, you know, so we take data points or bits, symptoms, and try to shove them into checklists, and if we don't factor trauma in, you're gonna get overdiagnosis of lots of things. And conduct disorder, I work 1 day a week at Lincoln Hills Prison. Anyone want to work there? I mean, we're in the news all the time. It's great. No, it's not great. But if you want to meet a population of highly traumatized individuals, prisons, jails, etc., you've all heard that. So I've got my girls, you know, I treat the girls, so there's like 35 girls at any given time. And if I didn't recognize the trauma they've been through, because they've already met how many shrinks, you know, along the way. And so if you try to do business as usual, they're not even going to talk to you, you know. They're going to just think, oh, here we go again. She's going to go through a checklist, give me a drug. It's going to make me feel terrible, get me fat. She doesn't understand me. She doesn't even want to. So conduct disorder is a checklist of naughty stuff you've done, you know. So oppositional defiant disorder is sassy stuff you've done, arguing and temper blow-ups. Conduct disorder is merely a list of rules that you may or may not have broken. It doesn't mean anything more than that. You still have to figure out, well, why would this 7-year-old be stealing stuff and punching kids and, you know, hurting the pet and stuff like that. So that's where a diagnosis doesn't really help us at all. And for a while, insurance companies, if they saw that diagnosis, they wouldn't even pay for it, because everybody knows that conduct disorder kids grow into antisocial personality adults, and there's no treatment. So why would we pay for them to go see a doctor? So forget it. So I don't write that down. My girls at the prison, do they all have conduct disorder as defined by a checklist of naughty stuff they've done? Oh yeah, you know, they have done lots of things. But it doesn't help me to understand them, and it sure doesn't help me to help them. So old school might be not even thinking of trauma, not checking on potential sources of trauma that might still be at play. Non-trauma informed care, so I'm not knocking men, but you know, in our culture, through history, you know, men are supposed to be tough and don't say anything's wrong unless it's like my arm is dangling by a thread, you know. But and I'll get to the ER at some point, you know. So the culture of toughness, the medical profession, you know, had started out at least like very authoritarian, paternalistic, just, you know, here, just take this pill, honey, and don't even need to know what I'm diagnosing or anything. So just tough it out. Or in mental illness, it would be, you should just pull yourself up by the bootstraps. Get over it. I can't even believe you're bothering me with that. Why would anybody react that way to such a tiny thing? Well, because maybe I'm triggered. You know, maybe this person said something, but they look and smell just like somebody that did horrible stuff, and I don't understand it either, and it blew out of the water, and I don't know why. So certainly those kind of get over it messages are not helpful at all. They're very off-putting. Power and control. So this is where you look around your physical plant and say who's the bouncer? Do you have security staff with a big, baton on their hip? Even keys, which it can't be perfect, right? We still have lawyers that make us do stuff. So it's not that you can have open doors to everything and open file cabinets full of sensitive information. And I mean, there are reasons to need things locked and on a need-to-know basis. But even keying in and out, like we go through our waiting room at Children's in Wausau, and you key in to the juicy area, I guess, like the clinical area. You have to badge your way in there. And so little kids are just like, what? So in their mind, something really juicy goes on back there. Well, if they never had a therapy appointment before, they're going to start to put together some idea of what goes on back there that may or may not be helpful. It might be just like, wow, that means once I'm in there, I can't get out, for example. So tone of voice, staff demeanor, the inclusive versus sit down, she'll get to you in a minute. It all adds up. As far as trauma-informed rule enforcers, like we have compliance, or even with medication, the tradition is to say they're medication non-compliant. Makes them sound naughty. And that used to just be it. They're naughty. They're not taking their medicine. Well, that's dumb, Why don't you sort through like, well, I can see that you didn't call for a refill until, like a couple months after I prescribed it. So can we talk about this medicine? Like, did you try it? Does it do anything good or bad? Can you afford it? All the other reasons, instead of just checking the box, non-compliant. And at the prison, they still have that. They would do a little form for me before I meet with the kids, and they just check non-compliant. So when I finally, woke up and read that form closely, I would start asking the girls, because almost every one it said non-compliant. Mostly it was their morning vitamin, because they were told they had like 10 minutes to get up, take a shower, eat breakfast, use the bathroom, go to the toilet, brush out your hair, and get in line for your medication. Well, if I was given that choice, I would skip my medicine too. So forcing too many tasks in too short of a time, that is just completely unfair to have that compete with something that maybe actually would be helpful. So I had them take that out of there. I don't care if they got out of bed late and you thought they were kind of grouchy or whatever. It shouldn't be held against them that they can't get all that stuff done in a row. So was it about the medication? No, it was about the routine, and the timing of everything. I've talked a lot about patient blaming as a fallback, and it's kind of an automatic thing to do, I guess, and some people are better at it than others, but it just isn't helpful. And behavior seen as intentionally provocative. So like the lady with the stroller, just like, she's gonna keep me waiting again, yeah, for 2 minutes, instead of feeling like, well, why is she attacking me? It's like thinking like, what's she been through in her life? What's she been through just on the way from home to here can be helpful. So manipulative, needy, attention-seeking, non-compliant. It sounds like just words, but it really helps build an attitude that isn't helpful. So even like attention-seeking, because I get asked, well, I don't know, I would say at least 50% of kids that have ever been referred to me have already been diagnosed with ADHD, so attention deficit disorder, basically. And what I oftentimes see is attention-seeking disorder, which to me is a symptom of attachment. I need more from my adults than they are willing to give or able to give. So they're seeking it. So I don't see that as they're naughty. I kind of applaud that. Good for you. You know you need more attention. You know you deserve it. You're not just going to give up on it. You're going to flip the teacher's pencil box over. You're going to, pull on the kids' clothing. You don't want to be ignored. You're seeking attention because you need attention. Let's see. Now, closed system versus open. That's another thing lawyers get involved in. It's not that we can, advertise, oh, we saw these people this week and we helped them all so much. So it's kind of an attitude, and as far as advocates go, we all need that. They don't have to have details of what we do behind doors when we're in a caregiver role or a doctor-patient or therapist-client role. But we do need them as advocates. So why care about this? Well, I've kind of been talking about that all along. Your outcome is going to be better if you recognize and factor in possible trauma than if you don't. So if we're really in this to try to help people, we'll be more successful. Everybody wins, because we'll feel better about what we do if we can help more people, right? So that one's kind of a no-brainer. Trauma recovery needs some reparation. You need your environment to help you repair the damage you've been through. So instead of triggering more trauma by angry looks or grouchy tone or, sit down, you've been up at the window too much, I'm not going to even answer your question now. So that kind of authoritarian stuff kind of helps the trauma stay entrenched, the trauma reaction. And if we follow trauma-informed care, we're less likely to take on the person's trauma, which is vicarious trauma. Or compassion fatigue, which that one's hard because the line when you're a caregiver is hazy, right? Most of us want to help more than we can or should. And so getting exhausted from it could be the body's way of saying, check those boundaries, Are you staying late? Are you getting there early? Are you, you have a desk or a big bowl of bus tokens on your desk, even though that's not really your role. Are you going to kind of use yourself up in the hope of helping others? So if you get fatigued by doing trauma-informed care, like Mother Teresa, like if you've ever read about her, she was deeply depressed a lot of the time, and I think it was because she was just flat out exhausted from doing good work. So it can happen there too. But compassion fatigue, if you're not doing trauma-informed care, is more just getting grouchy because things aren't going very well and deciding like it's them, it's not me, I'm perfect. It's these patients, they show up, they're too messed up, how am I supposed to help that? And then feeling like I don't want to go into work. So this shows up a little bit. And I just like this graphic because trauma-informed care means we're both on the same side of the fence. It's not us versus them. It's not authoritarian. It's recognizing that we humans get bumps and bruises along the way. And in that regard, although I'm not going to disclose, that's not a shrink's role, is to say, well, listen to what I've been through. That isn't our role at all. But I've never thought it hurt when people are super curious to make a global statement that most everybody you've ever seen is carrying around a burden, And to kids, it's easy to say, well, in your class, some kids wear glasses, right? Some kid might be on crutches. Some burdens are easy to see. And so it's easy for a kid then to say, everybody without glasses and crutches is living a perfect life, except the kid. And just to say, we don't automatically see other people's burdens, but behavior can be the fallout of trauma, and so it's good to recognize that and to see ourselves as on the same side of the fence. So, any risks about caring so deeply? Yeah, vicarious trauma. Next month's talk is going to dive into this pretty deeply, so I don't want to take away any thunder. I don't know if any of you are presenting it. But I just wanted to briefly, and I hope you don't get whiplash putting this on the camera, but just briefly say, what is vicarious trauma? It is a natural reaction from having trauma talked about deeply in front of you. Only a really unattached person can hear trauma and not absorb some of it. And as a caregiver, we're trying to absorb as much as we can, right? Sometimes, if you had a good day, a good night's sleep, whatever. But that it is natural that you might end up with actually symptoms from caring that deeply and taking on the trauma. So the most classic, I think, example of this is intergenerational trauma of children whose parents were in concentration camps. So the kid was born in New York City or Madison, but yet they react the same as their parents. They've heard the stories, they've looked into it, and the trauma can be there just from them secondhand experiencing that kind of trauma. So I'm going to skip, sorry about the slides here. So these symptoms of vicarious trauma sound very similar to post-traumatic stress disorder, which isn't unusual. So basically, you've taken on enough stress that your own brain is starting to change and put in automatic reactions in place. And some signs that you're kind of getting in too deep is when you aren't able to be open anymore and you're trying to close down their story instead of help them express it and heal. So, self-care is going to be talked about quite a bit next month. None of this is rocket science either. It's taking the time. I think even more than taking the time and exercising and eating right is knowing your own psychology. So that's why I keep coming back to that. Because if things are unconscious, they can cause an awful lot of trouble. And until you kind of recognize that, you're going to be kind of mystified and maybe irritable. So get away from work, rest, relax, exercise, be aware of things, connect to others. These are all, they all make perfect sense. Harder to put into action. So, trauma-informed care. Any questions? Easy to do, right? I mean, easy to read it on a slide. I think, well, I know at Children's, there's a big push all over the country. People are recognizing that if we don't start thinking this way, we're not going to be able to help people. Because to me, it kind of seems like it's peaked. Like the medical world is not helping as much as it used to for multiple reasons. But I would suspect that at least part of it is that we're ignoring, we're seeing the tip of the iceberg and we're not paying attention to the underneath the water stuff, which could be trauma. So thank you very much for your kindly attention.